Good morning to everyone, and thank you for the invitation to come and do our presentation before council. Thank you to the warden, to council members, and certainly senior staff and also to members of the public. I am LHIN Stevenson. I am acting chair, just temporarily in this position until a new chair is assigned to us. Our former chair, Norm Gamble, left us about 16 months ago, so it's been a while since an appointment's come across the desk, but we're very hopeful to hear good news in the very near future. I'd also like to introduce Michael Barrett. He's the CEO with the Southwest LHIN, and today he's going to walk you through the presentations. After the presentation, if you've got questions, we'd be more than happy to answer them, and hopefully you have a better understanding of what the LHIN does and what we're all about. So I'm going to turn it over to Michael.
Thanks, Linda. And how much time do we have?
No, 15 minutes.
15 minutes, okay. Am I putting the deck up on the screen? Or has everyone got a hard copy of it?
Everyone has a hard
Okay.
copy, but
No, it's okay.
should be able to with no problem.
Great. So thanks very much for having us here. Who knows what a LHIN is? Or have heard about the LHIN? Kind of. So there's a large slide deck here. There's a lot of information in it. I think I'll spend my time on the first part of the deck to just talk about what LHINs are, what we do, so you understand our role in the system. Appreciate you taking the time to do this. We hear consistently that people don't know what the LHIN is. Municipalities feel disconnected from LHINs. So we're trying to make sure that we go out to all the upper tier municipalities for sure, have a discussion with them, talk about what LHINs do. And we're also planning a number of other sessions. We were with the Oxford County Warden yesterday, and Don McKay from Restore Tavistock, and he's arranging an afternoon where the upper tier politicians, elected officials, the lower tier politicians are coming together for a day to talk about health. So the LHIN would be there, the hospitals, EMS, so that there's education for all the elected officials coming into that, which I think is a good idea, and we're certainly willing to do that here for if you'd like to do that. So what are LHINs? LHINs are not-for-profit Crown agencies that are responsible for planning, integrating, and funding local health services in 14 different geographies across the province. What do we fund? We fund hospitals, so that includes hospitals like the here in Perth Healthcare Alliance, divested psychiatric hospitals, so that would be the former London Psychiatric Hospital, which is now operated by St. Joseph's Healthcare in London, the Community Care Access Center, community support service agencies, mental health and addictions agencies, CHCs, which are community health centers and long-term care homes. So that list on the left, if you add up all the dollars that we distribute to all the organizations, over $2 billion in our geography. What's not funded by the LHINs, we don't fund physicians or clinics, we don't fund the ambulance services, and I'm sure this council is very familiar with the EMS, laboratories, preventive drug programs, and public health. These are the 14 different geographies that are covered by the 14 LHINs. We're number 2, so you can see we stretch from Long Point in the south up to Tobermory in the north. We're one of the larger LHINs across the province, and have a large number of health service providers that we fund. So we have over 150 organizations that we fund, from the big guys like London Health Sciences Centre in London, to the smaller Meals on Wheels, or VON, in the geography that we cover. So it's Owen Sound, Goddard, Walkerton, Hanover, Woodstock, Tilsonburg, Ingersoll, St. Thomas, Stratford, and all the places in between. Here's a description of our LHIN. As I said, it goes from Long Point up to Tobermory. Our population is about 924,000. Large rural population, obviously, as we head north out of London, but a large urban population within the city. Large proportion of seniors, and we have a large proportion of seniors along the coastline, because seniors are retiring to the Lake Huron shore, the Georgian Bay shore. So we're seeing lots of seniors there. And interesting dynamics with that, because we've got populations that are coming from Toronto that had high expectations for health services right next door to them, and things are different in the rural areas. 5 First Nation reserves and French language service designations in the City of London. Here's the list of organizations that we fund. We have 19 public hospitals on 32 different sites. 1 private hospital. There's a private hospital in the city of Woodstock. There's about 5 private hospitals left within the province. And the Woodstock Private Hospital really operates like a long-term care home. They have 16 beds, no surgery or medicine services are provided there. One community care access center. So the community care access center is the organization that provides home care. It has the same boundaries as the Southwest LHIN. 62 community support service agencies, so that's like Meals on Wheels or Dale Brain Injury, VON. 28 mental health agencies, addictions agencies. You can see 4 community health centers and all the long-term care homes that are publicly funded within the Southwest LHIN, and that includes municipal homes as well. So those municipal, or those dollars for municipally run long-term care homes come through the Southwest LHIN as well. We're governed by a 9-member board of directors, and that's Linda is our acting chair. You can see the other members that are part of our group. They cover the geography from north to south. We actually have 1 vacancy now, and 3 more people, their terms are expiring at the end of, before June of 2011. So we're just in the process now submitting nominations for new members to come into our board. The appointments onto our board are made by the government, so they're an order and council appointment. We make recommendations, but the ultimate decision is made by the government. We're waiting for our board chair position. Board chair, again, is an order and council appointment. It's made by the government, and hopefully we'll be hearing about that in the near term. Small staff, considering the geography and the number of health service providers that we have responsibilities for. Staff of 32, including myself and 2 senior directors. So what's different about LHINs than what's going on in the other provinces? The other provinces, I guess all provinces across Canada now are divided into regions on how they handle their health care. In the other provinces, they're called regional health authorities. And in those regional health authorities, all the hospital boards, the local boards for community agencies were all disbanded. And the regional health authority had 1 board that was responsible for all those organizations. So it would be like our board having the responsibility for governance over here in Perth Healthcare Alliance. What's different in Ontario is that the local boards have been maintained. So you all know that you have a board for here in Perth Healthcare Alliance. There's a board for the VON. All those boards have been maintained together with the board here in the Southwest LHIN. There's a lot of advantages to this. I think one is that if you have 1 board that's responsible for the geography that I spoke to, the scope of responsibility is immense. And how does that board ensure that you've got good governance across all those organizations with the amount of money that's being discussed here? It also ensures that we rely on those local boards to make local decisions. And I know the St. Mary's example is certainly a hot issue here in Perth County. We're very familiar with it. We rely on the here in Perth Healthcare Alliance board to make that decision. They ultimately had to come to our board because it was considered to be an integration. And an integration is where services are shifting between organizations. Our board ultimately had to give its seal of approval to that. But those local boards are maintained, which in all the other provinces that don't exist. In Alberta, they actually had, forget the exact number, 34 regional health authorities to start, went to 16, they went down to 1. So they had a super board that was responsible for the entire province. And you may have heard the CEO of that organization was the guy that was fired for eating the cookie on the press. He said he was too busy when he was talking to the press, or too busy eating his cookies so he could talk to the press. So people get always question what's the role of us versus the Ministry of Health versus health service providers. A simple way to remember is that the Ministry of Health is responsible for stewardship. So they set provincial standards, they set provincial priorities, and then they monitor population health. So how's the population health across the province? We're responsible for leadership and management of the local health system. So a good way to think of it is LHINs are responsible for how the organizations work together. So how is here in Perth Healthcare Alliance working with the community agencies, with mental health and addictions? We ensure that those organizations are working together. The health service providers, and that's our name for hospitals, long-term care homes, CCACs, they're responsible for the leadership and management of their own organizations. So we would never get into trying to manage what's going on in the hospital in Stratford, the hospital in St. Mary's. We're looking at the system perspective. We rely on the leadership team and the board to do that for example, here in Barrett County. So there's 5 areas of change. LHINs came into being back in 2006 when legislation wasn't introduced. There's a greater emphasis on local health system planning, increased community engagement, increased integration. Number 4, increased local funding and allocation. I'm a guy that used to work in the Ministry of Health many years ago, and I know how decisions were made back then. Quiet, always conversations with hospitals about, we need to get funding. Those quiet, always conversations don't take place anymore. They were made by bureaucrats. Now, every decision about funding, every decision about an integration is made in front of a public meeting with the board, so that the public has an opportunity to be part of that. And there's been a lot of attention focused on how open and public we are. There was an ombudsman's report which was quite critical about our community engagement process. And I can say, as a guy who worked in the Ministry of Health, things are way more transparent and open than they ever have been in the healthcare system. And if anyone wants to participate in those decisions, they have an opportunity to do that with our board or with our staff. The next 4 slides, I'll go quickly through them, just show the breakdown of funding. So this is the overall government of Ontario spending. You can see that approximately 40% of the government's operating expenditures are related to health. The other big chunks you can see are education and children's and social services. You take the next slide, and it incorporates debt repayment. So it's the exact same slide as the first, but you include debt repayment this time. And you can see that over 8% of the provincial expenditure on a yearly basis is going towards debt repayment. That number is increasing dramatically, considering the recent infrastructure investments. So if you hear different numbers about how much money is being spent on health, if you include the debt repayment, the percentage that's spent on health, it's the same number, but the percentage of the total pie reduces down. This is the amount of money that the Ministry of Health spends now. So this is taking the $45 million, dividing it up into what the Ministry of Health distributes their money to. You can see on the right-hand side, the big blue section is that the LHINs receive almost half of that money, so over $21 billion that come to the LHINs that we in turn provide to the health service providers that we're responsible for. The other big chunk on the left-hand side is OPEP, so that's physicians. So a significant amount of the provincial Ministry of Health and Long-Term Care budget goes towards physicians and physician payment. The interesting thing here is you look at public health on the top, 2%. So we spend all kinds of money on taking care of patients once they're sick, and the percentage of money that we spend on public health in terms of promotion and prevention is very small. And we're trying to shift that to ensure that more is spent up front so we're not taking care of sick patients once they get sick. And finally, this is our allocation, our $2.04 billion that we have responsibilities for. Almost 3/4 of it goes to the hospital sector, and then it's broken down into other parts. Long-term care homes receive about $276 million, or 76 homes we find. The Community Care Access Center receives $168 million. And then again, you can see the smaller community health centers, community support services are getting a much smaller amount compared to the overall budget. So the Act, which came into 2006, requires us to enter into an accountability agreement with the Ministry of Health. So for that $2 billion that they're giving us, we need to respond to them in terms of what we're going to provide back. We have a number of indicators. A lot of them relate to wait times for surgery, wait times for MRI, wait times for CT. All of those we're making great progress on. One that we're not making great progress on is cancer surgery wait times. Significant issue, 75% of the cancer surgeries are done within the London hospitals. And our approach within the LHIN is to try and get some of those surgeries out into the outlying communities. And that includes Woodstock, Stratford, Tillsonburg, Strathroy, St. Louis. There's opportunities there for additional surgeries to take place. And it means that residents from Perth County won't be traveling down to London to have that surgery. You've got great surgeons here in a lot of your hospitals, and we want to make sure that we take care of those patients. Okay. So there's lots of information here that we'll leave with you. I just want to show you some of the success that we've had. So in terms of the wait times that I spoke about previously, in 2007 when the LHINs had responsibility for the funding, the wait time for MRIs was 169 days. It's now down to 64 4 days, so a significant drop in the 3 years since we've been on that responsibility. CTs have dropped, knee replacements have dropped, hip replacements have dropped, cataract surgeries have also dropped. And Stratford's also going to have the benefit of the new MRI coming into the Stratford Hospital, which will ultimately ensure that your times are going to get lower here as well, and providing care and service for the residents in Perth County. So there's lots more information here. I'll leave it there more, and if there's any questions, I'm happy to answer them.
Council, any questions to Michael? Go ahead, Councilor.
I don't know if this is a question or a comment. I guess I'm concerned with the amount of time it takes for offloading ambulances in the facilities, because that reflects negatively on our EMS budget, and yet you are in control of it, and we can't control any of that. And I'd like to know what's being done to reduce that offloading time. And also, when you close emergency rooms, that reflects on our EMS budget also, and yet you aren't fiscally responsible for that.
I'll start with the first one, the EMS issue. There's no question this isn't unique to Perth. It's across the province where there's issues of ambulances waiting to offload the patients to get into the hospital. If you back it up, it's a system issue that you've got not enough beds within the hospital to have that patient get out of the ambulance and get into the hospital and be admitted. So what we're trying to do is to take care of those, we call them ALC patients, alternate level of care patients. So these are patients that are in hospital that no longer require acute care, that should be elsewhere within the healthcare system, in a long-term care home, in home, and supportive housing. Our percentage in the Southwest Line is about 13%. So 13% of our hospital beds have patients that no longer require hospital care, but there's no other place for them to go in the current picture. So we made a significant investment in with our Aging at Home program to ensure that you've got supports at home through the Community Care Access Center, so that those patients can get out at the back end of the hospital visit, so that there's a space available at the front end. When you've got other things overlaying that, like the recent flu that's come into across the province, the capacity of hospitals to react to that is a lot more difficult. So we're very aware of the issue, and we're trying to make sure we get patients out of the hospitals to make room for those patients that are coming in at the front door through the ambulance. And your second issue was?
That when you close the emergency rooms and reduce the hours, that reflects negatively on our EMS budget, and yet we have no control over that.
Right. So there's never been an emergency room closed.
Hours have been reduced.
C4, the hours were reduced during the evening hours, and it's opening back up on February the 1st. This had nothing to do with budget, nothing to do with finances. It was around in C4, which is unique around the province. It was due to a lack of nurses available to work those shifts. So they're in a much better position now. They're able to open back up again. The impact on EMS, there's no question, but I think we need to work closer together, and this is the difficulty of different funding sources and different responsibilities for EMS and for hospitals. We need to work closer together so that when something like that does happen, we know the impact on EMS. And I don't have the stats here in front of me. My understanding, the impact on EMS in C4 was significant at the start, and then it got into a better rhythm, but I don't have enough details around whether that was indeed the case. And the interesting thing about C4 is that you look at the type of nurse that they need to work in that overnight shift. So they're there by themselves, responsible for the emergency department, responsible for the inpatient unit. These aren't nurses that you can just pull off the street. They need to have the confidence and skills to be able to be there by themselves to be able to do it. And I think that's the problem with recruiting into our smaller community hospitals during those evening shifts. You need someone with great skills. Those skills aren't, all nurses don't possess them.
Any comments? Councilor Judge.
I know that you don't have, I assume, based on your presentation, you don't have the direct role, of course, of what happens within the hospital. You just provide the money for the hospital. But we do know that, and you've heard it, we reported, you obviously had the feedback about how much money has been paid for the upper administrative levels of the CEOs in the various hospitals and other related positions. And the criticism that comes out of the public is all that money that's being spent, and they see it reported, of big dollars, go to help to the nursing care or to the lower end grassroots work. He hit it on the nail when he asked about St. Mary's in particular, that closing its doors for emergency. You referred to Seaport. But if there was more money available instead of in the higher LHIN to be able to support the training as well as the availability of dollars to the frontline staff, but it did not help the situation. Right? Is there any admission on the part of the LHINs in saying, yes, there is excessive money being spent in the CEO and others in the administrative high-level positions?
So we do a comparison of how much when we provide them with the funding, they have to submit a budget back to us, and they break it down to show the amount of money that's spent on administration. If any hospital is out of line with their comparator hospital, then we take them to task on it and say that your administration costs are considerably higher than your counterpart hospital elsewhere in the province or elsewhere in the land. So if anyone's out of line, we address that. The issue around leadership within these organizations, our whole approach is around integration to ensure that organizations are working together. In Ingersoll, for example, the Ingersoll CEO left for a new position in Prairie Sound. The boards in those two, in the organization of Ingersoll and Tillsonburg, they came together and they now have a joint CEO between those two facilities. So they went from 2 CEOs down to 1. It's a conversation that we had at our board meeting yesterday. So we were in Elmer yesterday, and we were talking about the Goddard situation. So Goddard has a single site hospital with 1 CEO. Our board was very concerned about that Bill T. Bayer is retiring from his position. What's the hospital board doing about that to ensure that they're taking care of those dollars, those administrative dollars, and opportunities to look at other hospitals working together with Goddard? So, and we've had the same list of Wingham, and when they were recruiting for their new CEO, we were encouraging them to ensure that they would look at other opportunities for integration with other healthcare providers around their respective geography.
Just as a comment, and I'll stop talking. It's just not CEOs. There's a lot of people in management positions that are very highly paid, and which I share as a concern. And 2, I think it's wise, yes, if you can amalgamate 2 hospitals with 1 administrator, that makes sense. But when you make your comparison to another place, maybe the other place is high in the first place. I don't know if you've got good comparisons. You understand what I mean?
Sure, and you hear this in police services. If the police are making a certain amount in municipality X, they want the same as being.
But when you've got control over such a big area, virtually, what percentage again of the province you've got covered? You're in such a large situation, you should be able to have a broad control of what's happening with dollars, either in Ottawa, Windsor, North Bay, whatever.
Which we do, and the last point I'll make is, and I got to be sure that this is emphasized, is that with the local boards that are maintained, we rely on the local boards to ensure that they're hiring their leadership team, so their CEO. So the board of the Perth Healthcare Alliance is the board that would be responsible for hiring the CEO. Just like in Listowel Wingham, they have their respective boards are responsible for Carl Lewis. We don't get into the hiring of the CEOs, but if, as I said earlier, if something's out of whack in terms of where they're on their administrative costs, we take them to task because they have to report on it to us on a yearly basis. And I didn't get a chance to get into a lot of details, but with our service accountability agreements with the organizations, all these requirements around reporting come back to us. And if there's anything out of whack in terms of their surgery levels or their administration costs, there's a conversation that takes place to improve that performance.
Lynn, could you?
I have a question, actually, I'm the director of DMS for Perth County.
I think I've actually before.
It's related more to the fact of the comment about St. Mary's. And so what was the actual final recommendation and decision from the LHINs for St. Mary's? Was it a complete switch from an emergency-based hospital or to a urgent care center? Because we were led to believe it was only urgent care in the evening, and the daytime but there's been some discussion that the whole 24/7 will be switched to urgent care. So I just wondered what the final decision or recommendation was.
So the recommendation that was put forward by the Perth Healthcare Alliance was to look at 2 of their emergency departments going to reduced operating hours. But that decision has been put on hold pending the outcome of the provincial ER task force, the task force that was appointed by the minister. So when our board considered the recommendations coming from the Perth Healthcare Alliance, that decision wasn't even part of it. So all we looked at is the bed realignment in terms of rehab beds going to Seaforth and chronic care beds moving around to the different each of the 4 sites. The discussion around any changes to the emergency departments was not considered by our board and is on hold pending the outcome of that ER task force. So as of right now, it's status quo with the St. Mary's and Seaforth and Clinton and Stratford.
And when's the decision expected by that task force?
I don't know, because it's provincially driven. It's a task force that was put together by the Minister of Health, so completely outside of our control.
Is there any movement? I know that on the chart that was up there, that you're not responsible for non-urgent transportation, but it seems to be that a lot of the patients that they could get out of the hospital, and that would free up the bed. So, and one of the problems that's behind it is that there's really no regulations for any of those transfer companies. So any fly-by-night could put up a sign and take patients. So is there any move within the LHINs or within the province to regulate any of that and take some of the funding for it?
So I started my career in the County of Oxford. I was actually set up the 911 system in Oxford County, so very familiar with EMS. This issue has been around since then, going back into 1992, 93. Still hasn't been resolved. There was a provincial task force set up to look at it, which never went anywhere. Our board has recently given some funding to LHIN Health Sciences Center to work with its partners to look about setting standards for non-emergency transfer vehicles and personnel, because it's not happening provincially, so we want to make sure that we're doing it locally. The group is just getting off the ground, but there's participation from hospital reps from across our LHIN. So they are looking at it. How we implement that is going to be the more difficult part, because do we implement it just in the Southwest LHIN? How do we go beyond the Southwest LHIN borders? But this has been identified as a consistent issue for us, so we're tackling it. The implementation is going to be the tough part, though.
I would recommend that, since you're so familiar with Oxford County, so the director of EMS, which is Joe Pember, he's actually just done some significant work on that, and you might want to consider adding him to the task force.
Okay, great.
Go ahead, Jim.
Question or comment, I was always under understanding that a 1-tier level of healthcare in the province of Ontario. And you can correct me if I'm wrong. I was noticing in your slides, you actually provide funding to private hospitals, which I'm sure at some point in time, some people consider a 2nd-tier level of healthcare, which is maybe more available to more affluent people. So just wondered what percentage you did provide private hospitals and how that actually worked.
So it's $989,000 that we provide to the Woodstock Private Hospital. There's 5 private hospitals left within the province. There used to be about 26, and during when the Conservative government was in power prior to the Liberals, they went through and said we're getting rid of these private hospitals. The last big one that's left within the province is Schulich, which is not Schulich, the hernia operation. Shouldice, yeah, sorry. So Shouldice is the last big one that's left, and it has millions of dollars of funding. But they're very limited across the province. I think there hasn't been any action lately to get rid of the rest of the remaining 5. But it's a very, very small component of our budget that we fund.
Further questions, go ahead.
I understand rehab's basically gone to Seaforth for this area. And I'm very disappointed to see that, in particular for the older population. And around, we have midnight families that use horse and buggy, and how are they supposed to get to Seaforth to see their loved ones when they're in the hospital?
So it's an issue that we've heard before, and I think that the hospital is very aware of it as well. I hope the County Council understands the rationale for consolidating all those services at one location. It's to ensure that you've got the right staff taking care of enough patients within the Seaforth Hospital. If you've got a bit of rehab in each of the hospitals, you don't have the specialized staff that you need in each of those organizations to take care of them. transportation is an issue. So the hospital, our board has raised this with the hospital when they approved the integration that came before our board, and they've indicated that they're going to continue to work on it. I don't know what the answers are today, but it's been identified as an issue, and they're indicated that they're going to try and address it, because it is a challenge, there's no question.
Further questions? Seeing none, Linda, thank you very much. Michael, thank you very much.
Thank you.